Hello, this is ATTR 830, Evidence-Based Prevention. This is our discussion over the nuts and bolts. This is our first article is over the ankle, which was my article for this week. The article was a intervention study on a 6-year program done with Italian professional basketball players. The prevention program itself was split into 2-year bienniums, and so the first 2 years was a classical what they called a classic intervention for static balance, single leg static balance. The next 2 years was an electronic proprioception station, and the last 2 years was using the electronic station but increasing the intensity and decreasing the recovery time. So essentially what they did for the 6-year period for this basketball team was a wobble board or rock board, and then just a classic one that we would use in the athletic training room. And then after that, they made it motorized for incline and rolling effect to actually simulate what it would be to roll your ankle. And then what they did at the end was they increased the time that the athlete would be standing on the board and decreasing the recovery in between trials. So what they did was, that was the intervention. It was between 8 to 25 minutes, which kind of varied in the article, depending on what year of the study it was. They did have 100% compliance, which I would expect with professional basketball players. You get to control their lives, and so having 100% compliance made sense. It did have a result of decreased game and practice risk of ankle sprains by 81% after the 6-year study, comparing the first group to the last group. So they didn't actually have a control, but they used the first 2 years as a control of what you would normally do versus this new injury prevention technique. They also found no difference of the new versus the veterans, which I thought was an interesting part from the article. The article had 55 athletes involved in the study, but each year they brought in between 60 to 70% of new players each year. So it was a new group came in, and I think that was one of the big takeaways from the article when I was reading it, was that everyone's baseline was still the same, no matter if they were a new player transferring from another team to this Italian team, or if they were a veteran coming in, that they always came in with poor single leg static balance. And so even if other teams were doing injury prevention protocols, they weren't working to establish a baseline. So I think that kind of hit home for me on some of the criteria for that. So I guess the questions for this part is the injury prevention protocol in detail. So it was the wobble board, and they stood on it for between 30 to 60 seconds, depending on what year it was. The environment and the population, which I went over, and implement the identical program in your clinical setting. So what do you guys think about implementing in your clinical setting?
I don't really think it's possible with my clinical setting. As you all know, I work at a very rural, underserved high school, so just getting those resources wouldn't be feasible. I'm sure I could, do some modifications, but I wouldn't have like the electronic thing that rolls your ankle and stuff like that. But I could use, I guess, some of the basics, components and ideas of it. I also wouldn't have them for 6 years just because, they're in high school for only 4. So something I can consider, but significant considerations would have to be made to implement it in my clinical setting.
Yeah, I'm not even sure how, if ISD would even be willing to get in that type of technology. Specific to my population, I work with cheer and dance, so I don't think it'd be that applicable, but potentially for the men's basketball team here.
I think that was the thing that I was expecting for most people to come back when we had the discussion with the article, was that it's not feasible because it's electronic based. And I think what I was starting to think about when I was reading the article is that a lot of the stuff that we're switching to within sports medicine is technology based. So like the Sway app, or like the monitors that players are wearing on their chests and things like that, some of the new technology that's coming out. And the article also said that the system was portable, and so the board itself had the electronic built in, so all you needed was the board and a laptop, and you could take it anywhere you went. And it allowed for feed forward feedback, or feed forward visuals to the patients, which actually increased that they thought increased the effectiveness of the program. So they believe that them seeing themselves wobble on the screen kind of gave that feedback. And so what I started thinking about was when I worked at ISU in the clinic, the Biodex machine in the back essentially would do the same thing that they have back there. It allows it to tilt and incline, and it gives them feedback of where their foot is and stuff. So maybe not necessarily the exact one they use, but something similar that we have in the clinic.
And Zach, can you reiterate how often was this actually used as a preventative program?
Yeah, so they said that they did it at least, I think it said 4 times a week, but they had it during the entire training season, and it wasn't the same people in the study the full 6 years. So if you're thinking about having them in the 6 years, that's not the case, because it brought in at least 9 new people. So essentially they only had 12 people per year on the team, and 9 of those each year were new people. So the consistency between people wasn't the same, but each year they came in and had the same baseline essentially from the year before. So they did trials on the wobble board for up 30 seconds, and then once they got to the third stage, the third biennium, it was up to 60 seconds with a decreased recovery period in between. So they would stay on it for up to 45 seconds compared to 30 seconds while it was inclining. So I think in terms of like what we do in the clinic right now with the wobble board, it kind of mimics what we're already doing. It's just the addition of the electricity or the feed forward ability for it to rock and get some feedback from it. So I don't necessarily know if I would use it in my clinical practice, but the article in the discussion said like the ability to take this on the road, use it in hotel rooms, locker rooms, and airports made it lucrative for a professional team that since they travel so much. So I think that was something that I took away from it.
So my name is Ashley Crossway, and I'm a graduate assistant in the Doctorate of Athletic Training program. And I had the second intervention program, which was specifically designed for the knee. And my article studied the effectiveness of a proprioceptive and neuromuscular performance program called the PEP. It stands for Prevent Injury and Enhance Performance. They utilized this in a group of youth soccer players in Southern California. These were all female soccer players, and they ranged from 14 to 18 years old. And this was a 2-year study, and it had the 2 different reporting values. Essentially, what this study did is this program did, it had 3 basic warm-up activities, 5 stretching techniques for the trunk and lower extremity, 3 strengthening exercises, 5 plyometric activities, and 3 specific soccer agility drills. And this was very prescriptive. If you take a minute to look back in the article, it actually tells you exactly what to do, how many sets, how many reps, distance, time, etc. So it's very prescriptive. To me, at least, it seemed fairly easy for people to implement in their clinical practice. Obviously, the results of this were very specific to Southern California females 14 to 18 years old. And based off of what my understanding, this was like not necessarily an elite summer league, but a very popular summer league that people, were very competitive, not necessarily your leisurely activity. In terms of my clinical practice at the high school level, just looking through this is definitely something I can implement. Although I don't have a soccer team, you can easily manipulate some of these drills to, replicate basketball instead of doing soccer-specific skills. I thought it was pretty interesting. I was just wondering what you guys thought, if you think you could implement it in any of yours. I know Bobby has some soccer teams over at West, but the rest of you guys have your own unique setting.
Yeah, I'll go. So I think the way that the article laid it out for those the steps was very prescriptive, like you said, Ashley. And so I think it allows a clinician to adopt it pretty easily. And so I think it was something that you could adopt the soccer-specific activity, the agility exercises at the end for most of any lower extremity sport and just change it up for, say, like baseball or something for upper. But I think the part that I liked about it, that I noticed in a lot of the other articles that you all posted, was it provided a video and a packet of information. So it really focused on education and training who was going to be doing these. And I think that was something that hit home in all of these articles, and especially yours, though, Ashley, was for this to actually work, we got to have people that know how to do it. So,
Ashley, was this monitored for compliance and whatnot?
Yeah, it was monitored, and they also they did a very good job in terms of like research. They did control, so they match player like age and size and stuff like that. But it was also controlled. They had standardized injury reporting. They kept track of athlete exposure. So in terms of like your fundamental research, they did a really good job with those kind of controlling those variables.
Mm-hmm. I also think this can be modified. So I know that there are competitive, more competitive, more elite, I guess you could say. But I think this can be modified for high school sports teams too. And you can even just take out specific things and develop it into a warm up, especially if they don't really have a proper warm up or an effective one.
And I think looking at all the exercises they're doing, it looks like most of the exercises are pretty simple exercises. So if you have somebody that knows anything about stretches or anything like that, this could be easily be implemented, especially by an athletic trainer or a somewhat experienced coach. And also, I thought I think it said it takes about 15 minutes to complete the whole thing. So I mean, that's nothing for a warm up. I mean, you just take some talking to the coach and allowing 15 minutes for the warm up. I think it would definitely be implementable, especially in my practice. Most of the coaches are pretty lenient on that kind of stuff. So, and especially if it's going to prevent injuries in the future.
I thought this was interesting, looking at like what Zach was saying, some of the how specific they were on some of the exercises and how they had to do them kind of to a T, how it was described. And part of me is going back and forth on some of the agility type drills in my specific population. But I feel like I have a large appreciation of the biomechanics and how they need to be very specific. And if you're going to do these things, we need to make sure that we're doing them right. So I think that's something that can definitely be translated into my practice as well.
Okay, I guess I will go. So my article is focused on a general lower extremity prevention program. So overall, this focused on the FIFA 11 Plus program, which has usually been specifically for soccer athletes, female soccer athletes, but not for other sports such as basketball, specifically dealing with males. So this randomized control trial determined the injury rate through surveillance of lower extremity injuries and just general injuries as well. Basically, the population included 11 elite male basketball teams. 4 teams were part of the control group, while 7 teams were part of the intervention group, which was using the FIFA 11 Plus program in the 9-month season. Overall, each team used the entire warm-up before practice at least 2 times a week, and there's 100% compliance rate with that. And they only used the running portion of the program before each game. Every day of practice or every day of the game, the coach would actually compile an injury report for the researchers to add to the surveillance. So overall, the results showed that the warm-up program was effective in reducing injury rates in general. For the intervention group specifically that used the FIFA 11 Plus, injury rates for every 1,000 athlete exposures was lower in the control group, with a more significance for lower extremity injuries, including specifically the trunk, leg, hip, and groin specifically. One thing I wanted to mention with this was, again, this was focused on male population, not female population. So because females are usually at higher risk of knee injury, specifically ACL, this research mentioned that the baseline injury rates in this study using the male athletes may be too low to actually determine basically statistical significant differences between the two groups when considering relatively rare injuries. But overall, I thought this was interesting using the male population versus the female population focusing on basketball. But overall, in terms of the actual warm-up program, so it was focused on running and basically plyometrics, neuromuscular control, and strength and balance. So running included things such as running straight ahead, running with your hips out, running in circles, running and jumping, and then running with a quick run. So that was the part of the running portion. It also included bounding running, running and cutting, and running over with a pitch. So in terms of the strength and plyometrics and balance portion of it, they did include something like for hamstrings, such as Nordic hamstring falls, which I thought was very interesting. Single leg balance, so standing on one leg, tossing the ball while on the single leg, throwing the ball to the partner. Squats were also included, so they did it with the heels raised to isolate and basically get that anterior kinetic chain. Walking lunges, one leg squats, and then the jumping aspect of it included vertical jumps, lateral jumps, and box jumps. So in terms of my clinical practice, the people I work with right now, the athletes, track and field, cross country, doesn't include a lot of agility, which is what some of the running did with the running and cutting, things like that. So I don't think that would necessarily be applicable to my specific population, but the warm-up takes only about 20 minutes, and it did show improvements in injury rates, specifically to the lower extremity, in the control group, in the intervention group. So just because it's 20 minutes, I feel like it's relatively easy to implement. Is compliant with doing this warm-up with the entire team, or if they come in beforehand to the athletic training clinic to do it by themselves, I feel like it would be relatively easy to accomplish for each athlete.
So I had some, I guess, concerns with this article, and I guess reading some of the FIFA 11 stuff, I don't know if y'all agree with me or not, but the way that they modified didn't necessarily replicate the FIFA 11. So they removed the shoulder contact for part 1 and replaced it with just jumping up. So that is not really contact. So in basketball, I think they should have actually like jumped into each other, like going up for a layup rather than just jumping up in the air. And then part 2, they removed the bench and replaced it with a bending with both legs, which I don't know what that means. I just imagine someone bending over and touching their toes and standing up, and it's not what the bench looks like on the FIFA 11. It basically looks like a side plank. And so I guess I didn't understand that. And then the third part was I don't think they altered it enough to match basketball personally. So no one calls it a pitch in football. I mean, in basketball, like that's not a word that is common knowledge for people playing basketball. So I think that those were some things. And then my main issue I had with this was, what 13-year-old is considered an elite basketball player? Like, why did they throw the word elite on this? That this was, the average age was 13 to 15 for both of the groups. Like, how is that an elite basketball player? I just don't get that. So that was my takeaways.
Yeah. So again, because there's not really contact implemented with this prevention protocol, they basically said that with this modification, they focused more on landing mechanics and basically smooth, soft landing. I guess helping with neuromuscular control aspect of that. I feel like that's what most of this is really focused on, with the vertical jumping and things like that. Yeah, but overall, because there's really no contact associated with it, the contact aspect with basketball is something that probably causes most of the injuries with basketball, if I were to generally speak. So I feel like this would have to be modified specifically to kind of get all those aspects of basketball. And again, with the elites versus the age, it didn't make sense at all to me. But yeah.
I guess coming off of that, I guess my thing is, why would they go ahead and still call it the FIFA 11 plus? Why wouldn't they just call it something else or make up their own program? Like, if they have to modify it so much to meet the basketball parameters or whatever, they just call it something else.
Yeah, definitely agree with you on that one. They I don't know why exactly they called it that, but yeah, it should have been something different because of the way it was modified. But I definitely agree with you on that.
I agree that, they made a lot of modifications and stuff, but like reflecting back on Dr. Games's video and saying how, we can't just implement these without making considerations. To see some of the success they had, regardless of the changes they made, is also reassuring to know that, I can make some of these changes from the soccer warm to a basketball team. And obviously, as we talked about, a little bit more common sense modifications, and hopefully it'd work better. But it's nice to see that you can take something, the FIFA 11, that's been validated in elite soccer players, modify it into elite basketball players, and it's still successful to some degree. So I totally get where you guys are coming from. But as a clinician, trying to work towards prevention, it's nice to see some of the positive effects still carry over, even though significant changes have been made.
Yeah, I think actually that's a really good point. In that, I think from at least my standpoint, working with one specific team, I think that was where I was coming from with my comments. But coming from you was working with the multi-sport setting. Like, I can totally agree with you on that. I think one of the parts from the results that I was I guess apprehensive of, that they didn't really note if you actually get into some of the tables, was it was really only effective for acute injuries, not the chronic overuse injuries. So if you kind of get into that, I feel like they didn't hit home. They just like, oh yeah, it worked for lower extremity, but like the tendinopathies and the overuse injuries, which are most common in basketball, it wasn't really effective for. And so I think it prevented or decreased injury rates for some of the acute injuries, but maybe not a long-term fix too.
Yeah, Ashley, I like the point that you made that we are able to modify it and using things evidence-based, not just what's in the research, but using it based on how well it works in your clinical practice and on your clinical expertise as well. I mean, something as simple as doing the Y balance, using the board versus using the floor, they still work. So that's kind of an analogy I was thinking of relative to that. It's the same thing, and you can use it as, you could probably use it as a preventative tool as well. But that kind of goes to show the same thing that you're talking about.
All right, so we're going to move on to shoulder prevention program. So Bobby and I each chose an article for this. My name's Chelsea. I'm also in the Doctor and Athletic Training Program at ISU. I work with cheer and dance, and I also work a little bit with the baseball team. So I chose a prevention program specific to baseball athletes. This one, it was in high school baseball players. So the prevention program went over, it was 3 supervised training sessions per week over a 5-month period with 4 different testing sessions. So there was no control, so it was more like a kind of like a practice-based research with a prevention program. So the program was initiated at the start of the fall baseball season, and then went into the winter, went through winter conditioning. There were 11 pitchers or catchers who were identified as pitchers or catchers, and there was 3 players who were identified as position players. 4 of them reported having some type of shoulder pain throughout their careers, but none of them had any shoulder pain at the start of the program. So the 4 testing sessions that were completed, each of them were consisted of a posterior shoulder endurance test, a shoulder rotation strength test, and a glenohumeral joint range of motion. The interventions, it was a 2-phase preseason strengthening program. So the exercises that were developed were they noted that they were developed so they could easily be completed at the field. There was a emphasis on strengthening with endurance. So increasing reps with proper technique prior to increasing the resistive load. So one thing they also noted was that they wanted to prevent, that the age group, the high school age, with a high resistive load, because that could in turn result in poor technique. So phase 1 was weeks 1 through 10. This was an elastic resistance training. It was performed twice per week into longer durations if they had proper form. Phase 2 was weeks 11 through 20. These were done in the weight room, so they were using machines and free weights. These were progressed by repetitions until they were able to perform 3 sets of 20 reps, and then the load was increased. So over the 20 weeks, the consistency that was kept was 1 session per week was completed shoulder and scapular strengthening at every session. So I think the positive to this was they obviously had supervised sessions, especially because high school athletes, it can be difficult to get them to come into the athletic training room to complete exercises. So they had that, and then they had the supervised session once per week in the clinic. One thing that they did struggle with that they noted was they didn't have any control over how long the coach allowed the baseball players to participate in the program. So specifically to my setting, I'm obviously in a collegiate setting, so I'm not working with adolescents, but I could still make some of these changes. So instead of just focusing on low resistance and endurance, I can start with some strength because they're actually going to be stronger and have supervised in a strength conditioning room setting. And then obviously still incorporating that shoulder and scapular strengthening regularly, which they should be doing. I think they focus on that now in the weight room, but it's not, the program that they go through isn't administered through athletic training services.
I like the idea of it, and the endurance is a big thing, especially in baseball. But I don't know if it's my setting or my athletes in general. There's no way I'm getting them to come in for 20 weeks before the season even starts, multiple times a week. Like, it's great, but I have so many multi-sport athletes and stuff like that. But it was, positive to see some of those results at 4 weeks, and that I think would be more realistic. But anything over a month, there's no chance they're coming in multiple times to do. I mean, they're just not that dedicated, which is probably why we're so bad, but whatever.
Yeah. Well, I think sorry.
I just have a quick question, Chelsea. Did it actually say they were in the high school or they were just high school age?
Yeah, so right, because that's what I was starting to think, like, because they go through fall season, and then they were required to have weight room sessions. So because
it appeared to me like it was like a tournament baseball or like a traveling baseball team, because if you read in the demographics for them,
Elite.
Elite again.
Yeah.
If you read the demographics, they had 10 years of experience and the average age was 10 or 16. So that means they started playing when they were 6, and they usually practice for 11 months in a year. So you got to think about, these kids have a month off. So there's like, I just can't see them playing. Sorry, that's my dog. I can't imagine them being high school. They probably are high school baseball players, but probably are in a tournament team or a travel club team that I'm seeing.
Right. Yeah. So like it's separate from the school. So I don't know, probably a 14 and under team. So they're having regular practices every week, and then they're required to go to weight sessions. So I think that was easier for them to get this done. And I guess that can also mimic a collegiate setting because they're also kind of in the same type of program. But that's kind of crazy for kids this age.
Yeah, I would say bringing up, kind of feeding off of what Ashley was talking about, like athletes that play multiple sports, or like we got athletes, a lot of our real athletes play all year round. So I wonder if, I'm sure you're going to see different results if they are participating in other sports, doing weight training and stuff with other sports while they're doing this program. You're going to see, they're going to be fatigued, muscle fatigue, and different issues going on that may affect the results of things that you're seeing. So I wonder, did they mention if that was a limitation to this study, having patients that come in that could have been fatigued or things like that from participating in other things?
I mean, I remember reading at the end of the article that the compliance for people was really bad. So I can only imagine that there was some other reason that they weren't showing up. But Chelsea, I don't know if there was.
They discussed the distinguishing between fatigue and non-fatigue, especially with the posterior endurance test. You know, they're lying on the table, and so they said that was a limitation, but they never specifically really talked about, you know, just the going that long and still trying to commit to that. Yeah, that they just talked about it specifically to the endurance test.
I guess I think the authors even wrote so in there that this isn't a comprehensive injury prevention plan, and it's not this exercises are not effective in determining injuries and everything like that. So like I feel like they sold themselves short still, because I think when you were talking, Chelsea, about the PBR part of this, like when I was listening to Dr. Games' lecture, like the part where we want to have generalizable injury prevention plans just doesn't make sense sometimes. And this is what worked for this group though. And I think that sharing that with other clinicians of what actually worked makes sense. Like this worked for these people, and it probably is not going to work for Turkey Run, West Vigo, any of the other high schools in the United States, except for this little baseball place. And I think that for the budget, like if you think about it, getting elastic bands and doing this 2 times a week for the first 10 weeks, it makes sense for a lot of baseball teams to implement this to low budget, easy to do. But doing the next part with the weight room, like that's a whole nother part that you have to make sure the school actually has the budget and facilities to actually do that, and someone to actually monitor it. And I think the first part of this is really sound. The second part, I would be like, I don't know.
All right, Bob, you want to go ahead and talk about the swimmers?
Yeah, I'll go with it. All right, so I also did, my name is Bobby Vlandingham. I'm also a student in the Doctor of Athletic Training program, Indiana State. So the study that I chose, they did a 6-week strengthening program for the shoulder. They also included shoulder stabilizers specifically within that, and they also measured scapular kinematics, or like elevation, internal rotation, things like that of the scapula. They did a 6-week intervention. They measured pretty much all the shoulder motions that we have. So they measured shoulder flexion, extension, abduction, adduction, internal, external rotation. Then they measured scapular retraction strength, and scapular retraction with downward and upward rotation. So some of the exercises they included in that, they did obviously a lot of exercises to meet each of those outcome measures that they were measuring. So they did T's, Y's, and W's for the scapular strength portions. And then they did shoulder flexion. So they used TheraBand tubing for all these exercises. Shoulder flexion, low rows, throwing acceleration, deceleration, scapular punches, shoulder internal rotation at 90, and external rotation at 90. Then they also included 2 stretches, the sleeper stretch and then the corner stretch, which on the picture, it looks kind of confusing, but I assume it's for the pec. But it was kind of confusing what actually they were doing in the picture. And they didn't really explain it too much of what it was stretching. But those are some of the exercises they used. And they found that shoulder flexion and abduction strength increased in the intervention group, but it decreased in the control group. And pretty much they state that they didn't really necessarily relate this to actual injury prevention. Or they didn't say because of this you're going to have decreased injuries. But they did say that they did mention a lot about how increasing strength in swimmers, we know that having that strength obviously helps reduce potential injury. And having and stretching, not having tight musculature can reduce the potential for things occurring. So that was a bonus for this group. They also mentioned that within this population, scapular kinematics were more with internal rotation, protraction, and elevation at post-intervention, which they state that in most swimmers, because of the actions that they perform, that's pretty much the case. So if we can implement some of this as far as potential injury prevention, but everything as a whole, they didn't find really significant improvements in the strength. So it's not necessarily related. It's not directly related to injury prevention, but I guess if you were looking at swimmers and you had a bunch of swimmers that had decreased strength in these certain areas, maybe implementing this for those swimmers might be effective and potentially reducing injury in the future. Did anybody find anything that was caught your eye on this, or something I didn't mention?
Yeah, one of the big things that caught my eye when I was reading it is that they did this after practice, 3 times a week, I think it was. And I've never seen a Division I swim practice, and I'm assuming it's probably more intense than what happens at Indiana State. But most of these people are fatigued, and then you're going to have them do exercises afterwards. I just picture that increasing the strength of their bigger muscles in the shoulder, because the little muscles are going to be fatigued, so they're going to recruit the larger muscles. So, I mean, it kind of makes sense for that to increase their strength, but I feel like most of the time we focus so much on trying to increase the strength and endurance of the little muscles with, small weights and high repetitions that I don't know, I guess it just doesn't make sense to me, but maybe it's because it's, not a traditional approach to do it after practice. I just feel like you're going to fatigue the little muscles that are already tired and work on your, like your delts and stuff.
Yeah, Ashley, so talking specifically about the actual exercises that they used, I mean, the end result was, yes, there was increased protraction of the scapula, but there was also more internal rotation, upper rotation, and elevation of the scapula, which is what we really don't want. So I would probably, I guess, in terms of, just because there's a constant upper trap use when they're swimming, even though they're doing the intervention after practice, I guess, adding something to the program, possibly kind of upper trap release, and that probably would, I guess, help with the kinematic aspect of it, because there was not the proper outcome that was kind of looked for at the end. So I guess kind of modifying it a little more and adding more things, not just doing exercise, doing more soft tissue work as well, would probably help get better results.
The thing that I picked up on this article was, I don't know if anyone noticed, but one of the authors was one of the authors for the exercises. So it kind of goes back to some of the stuff Dr. E talks about with like soft tissue, special testing, that like you got to be cautious of who's validating this stuff, which I'm kind of glad that it didn't have the results, because one of the authors like picked all of his I's, Y's, T's in those articles. And so I wonder if he incorporated those into the study in hopes that this would work, and used it and didn't. So I don't know. That's something that I picked up on when I was reading, though.
And I think another thing, going back to when we should be implementing our interventions, they did this, and they mentioned this was a limitation, but they did it during preseason training. So their training they were getting after it already, and then they're implementing more stuff on top of that. So it's like you're getting double of that. So maybe when we're thinking about implementing these interventions, not doing it while they're in the meat of their training, maybe doing it during off season, things like that, so they're not getting double the load, and we'll probably see better results.
Okay, ready for the last one? So the final article that I looked at talked about prevention in the industrial setting. So this was a little bit different than some of the other prevention programs that we've looked at today. So this looked at specifically what they called participatory training. So they looked at what was considered kind of the gold standard for this kind of training. And then the control group had what would be considered their typical training, which would be less than the gold standard. So the gold standard of the participatory training was primarily looking at learning the skills to industrial planning. So they were looking at quality and safety improvements as well. Success stories from other factory or industrial settings. They looked at effective workplace inspection, so being able to recognize things, solutions of those improvements, needs assessments, and then figuring out action plans. They also looked at personal protective equipment and then some long-term planning in terms of like these needs assessments and problem solving and how to go about that. So the control group then had training. One thing I wanted to ask you guys was if you found more specifics or picked up on something I didn't pull a lot of specifics from the article about what the other training specifically was, other than it was similar to the first training, but it was just a short presentation, a lot less interactive. I think it said it was maybe like a 2-hour presentation, maybe less than that. So it was just a lot less intense of a training for the control group. And then, so the overall results of this, so they found a decrease in prevalence in the upper extremity. So the intervention group reduced from 16.8 to 9.9 percent. However, there was no significant difference observed specifically for upper back, low back, neck, shoulder, and elbow. So the first one was for wrist and finger. I don't know if I specified that or not. And then there was no significant difference for upper and low back, neck, shoulder, and elbow.
Yeah, I think, Carol, what you talked about with the didactic versus participatory is what I picked up on too. So I think what I got out of it was a 2-hour lecture versus a kind of a workshop or an event almost to figure out what you want to prevent, and let's figure out how we're all going to work together to do this. So I think making it more immersive for the workers or the employees at the factories kind of probably helped improve the compliance for it. I think a part that I took home from this article itself was that prevention and reduction are different. And so basically, I think the conclusion said it didn't prevent injuries, but it reduced the occurrence of injuries. So I don't know if that's a difference, and I don't know if I'm just saying stuff right now that makes no sense, but that's what I took away from that article in the conclusion, which I don't know what that means. But I think I think it helps me to make sure that I involve my patients, kind of back to last week with the stakeholders and that kind of including all the variables into this is what I kind of got out of this article itself, though.
Yeah, I found this interesting because this is kind of more of an abnormal type of prevention program rather than what you see in our regular clinic, kind of implementing an exercise program. This is more either verbal training or hands-on training to talk about things with experiences and figure it out. So I thought this was very interesting, realizing that prevention is not always just doing the rehab exercises. It's about talking and understanding about how to do certain things proper ways, not always physical hands-on things.
So, Carol, do you have any experience with implementing any type of prevention for the industrial patient?
So the site that I spent a year at the athletic trainer implemented part of this prevention or part of this training. So we had them, so like my portion was between like a 2 and 3 hour portion. I will say it started at 2 hours and it was very skimpy is like kind of a nice word for it when I first started working on it. But it's not like an athletic trainer who's involved in the industrial setting. That entire training is not all on the athletic trainer, but they're definitely involved in the process and involved in like when someone starts doing a task, then the athletic trainer goes in and looks at how they're doing a task and whether or not necessarily whether they're doing it right, but maybe whether they're doing it right for what's best for them, and also what's best for the team as well. But I'm kind of glad, like what Zach said, that someone else, because the results kind of confused me in this when I first read them, and I probably read them a couple of times before I started to have this thought. But so like in the industrial setting, there's like an injury, and then there's an actual injury, and then there's an injury occurrence, and an injury occurrence is not an actual injury because it doesn't have to be recorded. To me, I didn't take that would be how they were trying to describe the results of this study, but that's the only way in my mind that they kind of made sense after I really read into it and was trying to pull more from it.
When you created or worked with these programs, were they kind of tailored to what industry you're working with? Because in the article that you chose, there were so many different types of factories. There was like the electronic factory, the printing, plastics, jeweler, and I just picture them all doing very different things, and that having a very different effect on how you can prevent injuries. Because people creating shoes compared to people creating jewelry, I just picture them doing very different things. So, I don't know. I just don't know if this program was tailored enough, just like we talked about with, the FIFA for soccer as compared to the FIFA for basketball.
I think personally it has to be tailored. I will tell you, and I don't know, to be honest. Did not work in the industrial setting long enough to speak to this extremely well, but at my particular site, it was not tailored to job specific. The fact that I went around and watched them do their job after they started was supposed to decrease kind of that gap that you're talking about, but I don't think personally that that's enough. I don't know if other sites were doing that better than what our site was at the time. But ideally in a perfect world, this training is going to be kind of different for everybody. Somebody that, like what you're saying, is sitting, I don't know, maybe sitting in front of gears and has to push a bunch of buttons compared to somebody who has to lift 50-pound bags and throw them a foot. It's going to be, what you're going to talk to them about is going to be a lot different.
Yeah, as I was reading this article, I was very confused of what exactly it is that they were actually doing until now that you guys have cleared this up for me. So if I were to like take this information and try to apply it in something that I would see at my clinical setting. So if I went into the weight room and I had 2 people doing squats, and I spent 15 minutes on one kid, teaching him proper form, teaching him how to do everything right. And the other kid, I go over and I spend 30 seconds to say, this is how you do it, and go. The kid I spent 15 minutes on, he may still get an injury in the future, but there's probably a better chance that he won't develop low back pain or something like that because he now knows how to do it correctly. But the other guy probably has a better chance of having potential injury in the future because I didn't spend enough time with him showing him how to do proper form. Am I kind of relating that correctly or somewhat?
I think that's
so,
a good frame of reference, Bobby. Go ahead,
yeah,
Zach.
I agree with Carol too. And I think the part too about it is that it's not necessarily always time. I think from this one, it was them participating in the design of their prevention training. And so rather than me telling you, hey, you need to do a squat right, they were identifying that people were doing squats wrong. Then they discussed how we're going to change that, and then they made a plan to change it themselves. That I think back to last week's articles about like active surveillance or active injury prevention, that they have to take reign of their own prevention sometimes too. All right, so we have a few other questions to go over as a group, so I'm gonna moderate if that's okay with everybody. All right, so first question is, why don't you implement a comprehensive injury prevention program? What barriers are keeping you from implementing prevention programs?
I don't think I've had an issue with implementing a program with my specific teams. I think the cheer and dance teams aren't really looked at that much. So when I do bring something to the coach who's really open to it, same when I go to the weight room to have a discussion with them about possibilities. And so I've developed one for the dance team, specifically to baseball. I'm not the main athletic trainer that works with them. So I think that would be a barrier. And so I guess it just depends on if she's willing to put in the effort for that. But I also think the baseball team spends a lot more time in the weight room than my teams do. So they're already being involved in exercises that can be, looked at as preventative exercises, but I'm not sure if it's a specific program because they're constantly changing. So that's my setting, but I don't think anything's holding me back.
Well, I would say, right now with track and field at ISU, we're implementing a hamstring protocol. Eric, one of the soccer athletic trainer, went to Europe over the summer, and went to a specific hamstring seminar. So we've been taking the research article and his experience from the seminar and implementing 3 specific exercises for patients who start having hamstring tightness, and we encourage them to come in for during treatment times, and it's actually been working pretty well. They've been continuing to do, and there haven't been a lot of issues with it. They're pretty compliant with it, but also we do have a program for the in the weight room as well. So I think a lot of the prevention makes it easier when you are not just putting it on yourself, you're putting it on the coaches and also the strength and conditioning staff. I feel like utilizing the strength and conditioning staff is a great resource, and it takes some of that off of our plate because we do have time constraints. So like they're doing now, they're already implementing a large hamstring protocol that we actually got laminated. So I feel like it's been going well, but figuring out that it's not just you, utilize everyone and all the resources that you have.
Well, mine is definitely just going to be time and resources. And it's not just my time. It's kind of what I talked about before is I only have so many athletes, so there's not really an off season for nearly any of them. And then so many of them are involved in clubs and they have to work to help support their families. So to, make practice a little bit longer, that's a whole other constraint with the coaches and things like that. And I'm sure I could get some buy-in from my coaches, but I also don't have the ability for like a strength and conditioning coach to do that in the weight room, things like that. Not even really in PE because, they've got to go through what they got to go through there. So I'm sure I could do a better job. I just don't know if there would be a comprehensive buy-in. Plus, there's so many different sports. So I'm sure there's something I could work on, but it would be difficult.
Yeah, sorry, Bobby. I'd have to agree with Brittany on I tried when I was at basketball. So what I did was I took FMS scores and then took that information back to the strength coach, and they designed individual versus like community or for the whole team based injury prevention. And so I don't think I did a comprehensive ones, but it was more individualized based on their deficits. And so I think that it worked for me, but I think the time aspect, what Ashley brought up, makes sense, and it made sense for me too, that just as busy as a high school athlete that has to leave to go after work, a Division I athlete that has autograph signings to go to, which makes no sense for people sometimes, that they have their lives dictated every minute of the day, especially for men's basketball at ISU, that we didn't have time to do extra stuff. So Ashley, I actually have an article about implementing injury prevention in PE classes, that one I accidentally sent out. So it's, if you're interested.
I read it. You get people fit.
Yeah.
And then I was like, Zach, this doesn't make sense. But
Yeah, that's
Yeah, I would say there's really no reason why I'm not implementing. I mean, I could always do it. I think we're really getting into learning the real ways of how to do it and things like that. And it would just take me sitting down and finding the time to go through my data and determining what is the best way to do it and what do I want to attack. Because I mean, we know we can't attack everything, so it's fine. I just need to sit down and find what is one area that I think I will get the most benefit out of, and just doing it. I mean, really no reason why I can't do it. I just got to do it.
I think a big thing for me is like when we've tried to make changes before, implement different things in the past, we not so much getting stakeholder buy-in isn't an issue for the most part. Owners are typically on board, but getting that translation from the owners to the coaches, and not just to a couple of the coaches, but also to all of the coaches. So sometimes certain coaches will implement something and think that it's great and understand why
Hey, Carol, your microphone's breaking up. All right, so we're gonna go on with the next question while Carol internet connects back. So the second question was, if you do implement a prevention program, has it been successful and how do you know? So I think a lot of us answered that question. So Brittany and some of the other people. Well, Carol's back. Do you want to finish talking about your implementation of your program?
What was I saying? Or what, did you hear anything?
Yeah, you were talking about the coaches and the owners not translating information back and forth.
Okay, sorry, mine keeps going in and out. You guys are going in and out a lot too. Just because some of the coaches, so when we've tried to implement things in the past, sometimes like maybe 50% of the coaching staff will implement something or understand why it's important and that it needs to be implemented before a workout, but the other half may not. So I think going about it in a way that it's a requirement, it's more of a requirement that they have to implement it before practice rather than this is something that we want to do and this is why we want to do it, but then they just don't do it.
All right, so the next question is, how can we as a profession shift our model from a reactionary, one focused on evaluation, treatment, and rehab, to a proactive model, one focused on prevention?
I think one really important thing that Dr. Games pointed out in his lecture earlier is we don't stress it enough in the undergrad education. We spend so much time, on evaluations and, management and treatment and rehab. We don't talk about preventing the injuries from the start. And I think if you do it at the elementary, the core level when we're learning things, it becomes a part of our philosophy and, the way we think. It's definitely gonna be hard to change the mind of, the thousands, tens of thousands of athletic trainers there already are, but it's one way to definitely change the mindset is to start with the new generations of athletic trainers.
Yeah, I definitely agree with Ashley, focusing not just on passing the BOC, but focusing on all aspects. Even things like patient-rated outcome measures, not specifically focused on the undergraduate. So even now it's hard to kind of do that. So implementing that so it's instilled and we know that it's a general norm that we really have to do it and should do it, that would help a lot.
Yeah, I'd have to agree with you guys too on that. And from the other aspect, I don't think we give ourselves enough credit sometimes that we may not design the prevention, but I think during this discussion, at least 2 or 3 of us, including myself, have called it a warm-up, and that we didn't need to give ourselves credit sometimes that this is actually happening at our sites and with our patients. We just may not be leading it, but at the same time, we need to be better and more vocal, more advocate better that we know how to design, or we think we know how to design good prevention programs, or at least be in the mix of the discussion. and that if people are doing warm-up programs for their teams, we gotta start somewhere. So I think that sometimes we gotta say that's a good start, and we're doing fine at that place right there.
So I'm glad you said that, Zach, because I think that's a good point too. I had to create a dynamic warm-up for the cheer team just because they weren't doing it. But I think the issue is going to be is the athletic trainer coming in next year, getting them to buy in to continue doing it, because they're lazy. The cheerleaders are lazy, and as soon as I leave, Miko, stop. Sorry. As soon as I leave, they're going to be like, oh, Chelsea's not here to hold us accountable anymore. So we don't need to do it.
All right, so the fourth question is, how can you as an individual clinician shift your model of practice from one focused on evaluation to one focused on prevention? So rather than the profession shifting our own model.
I think for me, it would just be, I don't think necessarily I have to totally shift, but like include it into my practice. So like right now I'm thinking with our basketball team, our assistant coach runs them through their warm up. Is they do karaoke, high knees and stuff. Why don't I just say I have this program that's might be a little bit more effective. Why don't we do this? And then I can track the data and all that stuff. So I don't know if it's actually shifting, if I would consider it shifting my whole practice, but including that as part of my practice, since it's already being done by assistant coaches, why not just implement my own thing, take the same amount of time, and be able to track that that data. I think that's from my.
I think Bobby said it really well for the last question too, because I don't think we can only focus on so many things at one time. So I don't, in my mind, it's not about shifting the entire model. I think it's about implementing small steps towards making that change. So if that's our long-term goal, then we're going to figure out what small steps we need to take to get to that long-term goal to make sure that we're successful in changing that mindset or changing the model in the end.
Yeah, I agree with you, Carol and Bobby. I think for me, when I was listening to Dr. Games' lecture, I'm sorry, Dr. Games, I just didn't agree with the part with the generalizable, like researcher versus clinician base, that we need to have like the big studies on prevention. Like it just doesn't make sense to me. Like our patients are too unique and our settings are all so unique that right here we can't all agree on implementing one program itself. That I think PBR based research on this and actually doing stuff ourselves and making those small changes like you talked about, Carol, is how I want to change my clinical practice with this. Is that I don't want to change the profession in terms of injury prevention. I want to make sure my clinician or my patients are getting better. So I think that I valued like the article Chelsea shared from ATSHC, like it was so easy for a clinician to adapt that and understand it, that is something that I valued from how to change my clinical practice.
Well, I think that's a good point, Zach. And I think by focusing on that, we can make the change in the profession. You know what I mean? Other athletic trainers within the profession are seeing us do this. So I think that's the way that we're going to end up making a change instead of saying, hey, you need to change.
All right, and the last question for tonight is, what questions do you have about the nuts of bolts? I think it's supposed to be nuts and bolts of injury prevention programs, and what you need to be successful?
I mean, I think this is hard to answer, just like you said, Zach. Like, it should be more PBR based and, individualized, where I think at some point it's going to take trial and errors. You can't teach somebody how to convince a coach. I mean, you can teach them techniques to try to present information to coaches and things like that. But everybody has a unique patient population, unique setting, unique coaches, unique resources, that it's in some way it's going to be like a PBR and it's going to be trial and error. Obviously, the more information we have, the better guided we can go into it. But just like these programs, there's nothing that's going to fit everybody. Just like I can't serve it up to you on a silver platter, essentially. We have to all try ourselves.
So I'm thinking everyone's kind of agreeing, got some nods. Anybody else have anything else to add for the discussion tonight? No? All right, so this concludes our discussion for evidence-based prevention for the nuts and bolts for ATTR 830. Thank you for listening. Have a good evening.